Hey, it's a delight to be here. I'm happy I can still breathe at this altitude. And I'll just say, remember to stay hydrated, and if you're on low carb, follow Andrew Mente's advice, and particularly because of the increased sodium excretion associated with nutritional ketosis, you should get at least 5 grams of sodium a day. Okay, that's my tip today. My talk today is one of the topic I've been kind of developing on my own for about 20 years, and that's trying to understand the role that inflammation plays in health and disease, and particularly the impact of nutritional ketosis on inflammation. And when I go back and look back, I actually can see evidence that of a beneficial effect, and I'll show you what I think beneficial means. As early as far back as my PhD dissertation research, which I finished up in 1980. So that gives you a sense of how far back so the clues of this for me go. Let me start, and I have to make sure I push the right button. I assume it's the one on the right. Yeah. So by way of disclosure, I am heavily conflicted. I'll just say that outright. I worked in academia for 20 years. I maintained a really clean existence, no conflicts, and I got no funding to do any of the research I wanted to do. So in 1999, I went over to the dark side, and I've worked in a couple industries. And most recently, I met a remarkable world-class athlete and internet entrepreneur, Sami Inken, and he convinced me that we should turn some of this into a scalable, high-quality intervention, and that's what Verta is. And the only data I'm going to show you from Verta is data that we've published. In fact, what I'm going to try to show you is the only data I'm going to show you is published in the peer-reviewed medical literature for all the stuff I'm going to present today. So there should be no conflict if it's gotten past the peer-reviewed process. So the primary molecule that we have circulating in our blood when we're in nutritional ketosis is called beta-hydroxybutyrate, or BOHB for short. Or you can call it BHB, or you could call it Fred, I guess. But this is a little molecule, little over 100 molecular weight. And for most of my career, my assumption was this is a really good fuel for the brain and the heart. And the body can use it in place of glucose for the function in those organs. And so therefore, it could help you get by on a low-carb diet. But the science of beta-hydroxybutyrate has burgeoned since 2013. And we now know that it is a very potent inhibitor of enzymes, which in turn inhibit our defenses against oxidative stress. So it inhibits something which inhibits us from not being damaged by free radicals or reactive oxygen species. So we know the mechanism, the precise molecular mechanism through which it does this. And it has nothing to do with being a fuel. This is functioning at the gene expression level in terms of basically altering our body's defenses. We also know from a subsequent study published by the same group that they called it more than a metabolite, but in this discussion, Eric Verdin and John Newman point out that there's evidence that beta-hydroxybutyrate directly reduces insulin resistance. So it's an anti-insulin resistance molecule. Again, the pathway for that is being worked out. Parallel to that, a group at Yale University collaborating with Dominic D'Agostino at University of South Florida characterized the fact that this molecule, beta-hydroxybutyrate, works in the nucleus at the gene expression level to suppress the function of something called the NLRP3 inflammasome. And what you get from the point of view from the term inflammasome, this is a molecule. This is a assembled molecule when it's put together, turns on the body's inflammation, and this is reduced by beta-hydroxybutyrate. So you begin to get a sense that this is not just a fuel, this is not just a metabolite, this is something which has fundamental effects within the body, and specifically it has effects on the regulation of the body's inflammation. Now, why would we be interested in that? I mean, inflammation, we know, when you have a fever, that's a high grade of inflammation. Fever helps your body in its defense against infection. If you have inflammation at a cut site, that helps healing. Inflammation is a good thing, but the question is there danger from having too much of it? And just recently, just in the last decade, it's become increasingly apparent that inflammation is a primary driver for the development of type 2 diabetes. And so here is an early paper published in 2011, type 2 diabetes as an inflammatory disease by very respected authors. And then Gerald Olewski and a co-author from University of California, San Diego, published in one of the top-tier journals in medical research, pointing out that inflammation is a significant driver of metabolic disease. So this is linking us to this signaling molecule to something which is at the root cause. And I would say this probably goes much further down into the causation than, say, insulin per se. Because insulin's a messenger. Insulin's not a cause. And I don't want to belittle this, but when people say, well, you know, isn't insulin the cause? I say, well, that's kind of using insulin and blaming that for type 2 diabetes or for insulin resistance is like blaming your cell phone for robocalls. It's just the messenger. And you have to get deeper in to find what drives that. And then the other important question is, does changing it have any impact on the disease? And that's what I want to focus most of my talk on. So again, the place where this really began to gain traction was not in diabetes, but in coronary artery disease. And back in actually as early as the mid-1980s, but in the early 1990s, there were a number of papers published that examined epidemiologically the relationship in cohorts of healthy people, looking at the total white blood cell count, where the number of white blood cells, again, is probably the earliest known marker of inflammation. Looking at the level of total white blood cells in healthy people whose white cells are in what was considered the normal range, and looking at their subsequent risk of developing coronary artery disease. And what both these papers pointed out is that for people who had lower levels of white blood cell count in the normal range, that they had a lower risk of developing heart disease. And if you look at the numbers here for the bottom paper, this one by William Cannell, who headed the Framingham Project for about 2 decades, they followed almost 1,400 men and women. Their white counts were in the normal range at baseline. But when they then looked at their risk of developing coronary artery disease, that it was increased 34% in men, and I'm sorry, 32% in men and 17% in women per 1 unit. Now we measure white blood cells as 1 times 10 to the 9th. The normal range is roughly between 4.5 and 10. So for each 1 increase in that normal range, there is something around a 20–25% on average between men and women increase in coronary risk. So if you have a number of 5 versus a number of 8, that's 3 times that number. You're essentially looking at doubling the increased risk of heart disease strictly around white blood cell count, independent of total cholesterol or its distribution in lipoproteins. So this is something that is not a cholesterol-driven aspect of coronary risk. Then the question is, does changing it make a difference? Now, up until recently, we haven't had any medications that are safely used chronically in people to lower biomarkers of inflammation. They say, well, you can use aspirin, you can use Motrin, and those are anti-inflammatories, but they only work through the eicosanoid pathway, not through other inflammation pathways. And they don't really significantly drop these biomarkers. So it turns out that the modern statin drugs, Rosuvastatin and Atherosclerotic, which were developed to lower LDL cholesterol by reducing liver cholesterol production, that they also lower biomarkers of inflammation, particularly one called C-reactive protein. And again, there's potentially a bit of conflict of interest here because the guy who developed the high sensitivity CRP, C-reactive protein test, Paul Ridker, is the one who's been doing the studies looking at what happens when you change it. So he has a bit of interest in having a patent on the assay. That said, they did a massive study where they took 17,000 people who were selected for not having a markedly elevated LDL. So the LDL was under 130, but they screened them and screened out people who had elevated C-reactive protein values. So normally theoretically, you would give a statin to somebody with high LDL, and they were picking people with high CRPs. And they intended this to be, I think, a 4-year study, and they randomized into 2 groups. They either got the Rosuvastatin or they got placebo. And they ended the study after 1.9 years when the risk of primary coronary events was cut almost in half in the people who got Rosuvastatin. It was a dramatic effect. But the problem was, although they selected people for relatively low LDLs, their LDL was further reduced by 50%. But their CRP was reduced by 37%. And so, both of them went down, and you can't ascribe which of these, or to what extent either one of them reduced the coronary events. So, it's a very promising study in terms of maybe the reduction in inflammation was important, but you really can't tell from that study. And then along came a monoclonal antibody. It was developed for people with rheumatoid arthritis. So this is a targeted monoclonal antibody against interleukin-1 beta, which is one of the many biomarkers, but also inflammatory mediators that we look at. And so this is an injected drug. It's very expensive. You inject it every 3 months, and they gave it at 1 of 3 doses versus placebo in a group of people who were otherwise healthy and looking to see what would happen to their coronary event rate. And what they found was that there was a dose response effect on coronary risk that went from 0.93 down to 0.80. That's the relative risk. So if you got the dose that took you down to 0.80, you had a 20% reduction in coronary risk. And this is with a monoclonal antibody directed at a single protein and had no effect on cholesterol or lipids. So the good news is it proved that lowering inflammation can, in this case, lower coronary events. So there is now, we're very confident that this is a causal relationship. The problem is that when you target a single component of your body's defenses against infection, guess what happens? It's like taking the manhole cover off a manhole in the middle of a street, and people disappear. And so they saw an increased death rate from sepsis that counteracted the beneficial effect of this in terms of reducing heart disease. But that's a really important thing to understand, that inflammation is not just an associated factor, it's a causal factor in coronary risk. Now, you'd say, well, why don't we use nutrients to modulate inflammation? Because we know there are lots of anti-inflammatory nutrients. And you heard some of them mentioned today. And fish oil, or DHA, is touted as an anti-inflammatory, and indeed it is, and we know the pathway. But when you look at measured biomarkers like the white cell count or CRP or some of the other biomarkers, its effect is very, very modest. There's a naturally occurring omega-6 fatty acid called gamma-linolenic acid that you can get from evening primrose oil or borage oil, and it has it boosts the body's production of what are called class 1 prostaglandins. It has anti-inflammatory effects, but again, they're very modest and not of the caliber that we were looking at here with reductions in CRP of 30 or 40%. And then the much touted resveratrol, which is found in dark fruits, including dark red grapes, and found in wine. Again, given in very high doses to animals can shown to have effects, but it's very hard to show anything like this kind of effect in humans. I do want to mention that I was involved in research with a compound called gamma tocopherol, and you all know that tocopherols are a class of vitamin E. And the class the one that we're all told is the most important is alpha tocopherol. And so when you buy vitamin E, you're getting alpha tocopherol. And that's because in the test tube, it is the most potent antioxidant, but it has almost no anti-inflammatory effect, whereas gamma tocopherol is a quite potent anti-inflammatory. And working in a previous setting, I did research, and we published data on people with end-stage renal disease who have high CRP levels, and we showed that gamma tocopherol alone or in combination with DHA can dramatically reduce CRP levels. It would be great if we could be studying that, but unfortunately we filed for a patent on that compound and that formulation. And then the startup I was working for didn't want to do dietary supplement work. They want to do pharmaceuticals, so they weren't worried about doing anything with that. And they went bankrupt trying to come up with a drug to do something like that. And then Johnson & Johnson bought that patent. They've been paying this is not a conspiracy, this is just normal business. They've been paying the maintenance fee on that patent since 2005, and they've done nothing with it. And by the way, they own the brand names of Tylenol and Motrin. So there's a nutrient combination that can have this kind of effect, but we aren't going to have access to it for a while because it's blocked under patent. So let me then share with you what we can do with a well-formulated ketogenic diet in terms of biomarkers of inflammation. And this is a study that Jeff Volek did with his graduate student, Cassandra Forsyth, and my name's on the paper because I was kind of the old advisor fly-on-the-wall guy. Fun to watch them do this. They took 40 people with metabolic syndrome, which is essentially pre-diabetes, and they randomized them to one of two dietary interventions. One dietary intervention was a low-fat, relatively high carbohydrate diet that was restricted to 1,500 calories a day. The other one was a high-fat, low-carbohydrate diet, moderate in protein, and they ate that to satiety. And the reason that they ended up being the same amount of calories intake on the two diets is because that was a satiating diet for the people on the low-carb diet. So they matched caloric intakes, one by restriction and one by just like restricting total calories, one by restricting carbs. And they followed this for 3 months. They looked at a whole bunch of factors. I just want to show you weight loss and metabolic syndrome data. So this is weight loss. And so you see the two curves. The upper one is the people on the high-carb diet. And this is typical when you compare side-by-side high-carb and low-carb diets in matched groups of people. So about double the weight loss for the people on the ketogenic diet. And there were a couple on the ketogenic diet who had marked weight losses, but you can see that the average weight loss for the low-carb group was slightly greater than the greatest weight loss in the other group. So it wasn't just a couple outliers who skewed this. This was a consistent pattern of greater weight loss. And again, we're told, but it's mostly body water, It's only about 1 kilo of water, and that's water associated with the glycogen that's in muscles, which is reduced about in half when people initially follow a well-formulated ketogenic diet. So significant weight loss, but they're both still losing weight at the end of 12 weeks, and that's important because they're still in a negative calorie balance for each group. The boxes here in green, this is a complex slide, but the boxes here in green, this is abdominal fat, so central obesity, blood triglycerides, HDL cholesterol, and blood glucose. These are all parameters from which we define metabolic syndrome. And you can see that in all cases, the results from the high-fat, low-carb diet were significantly improved compared to the high-carb, low-fat diet. And so there was a very significant effect on metabolic syndrome in these individuals. But we also measured a panel of 14 different biomarkers. We basically took everything in this alphabet soup of biomarkers of inflammation, every one we could find a test to measure, and measured all 14 in both groups. And for 7 of them, there was no difference in the response to the two groups. Now, this isn't response from baseline. This is difference in response at the end of the study. And so for none of these biomarkers was there a superior result for the high carbohydrate group. But for 7 of the biomarkers, there was a significantly greater benefit against these biomarkers of inflammation for the low carbohydrate, high fat group. So statistically, that's a very powerful result indicating a superior anti-inflammatory effect in the context of weight loss done in two well-matched groups in parallel. And that's where we were up until a couple of years ago when I met a remarkable person, and you'll meet her tomorrow. She'll speak to you tomorrow, Dr. Sarah Hallberg, who is a physician in Lafayette, Indiana. And she had switched her practice in Lafayette from a standard internal medicine practice to a predominantly low-carb practice for dealing with severe obesity and type 2 diabetes. And she approached me 2 years ago and said, this is amazing. This is having great results. But some of my patients' LDL levels are going way up, and we got to figure out what's wrong with them. And so we decided to do a study. The study was roughly 500 people recruited in the Lafayette area. And 400 of them had either type 2 diabetes or metabolic syndrome. The majority had type 2 diabetes. And close to 100 of them were recruited from the usual care group from their diabetes clinic. And I'm going to show you a little bit of data from 262 of the people who had type 2 diabetes who we followed for the first year. So Dr. Hallberg is the PI on the study. To do this, our protocol is a very intense, either in-person hands-on or very intense through an online app where people are having contact with their coach daily, sometimes up to 3 times per day. And so the coaches that work with the patients are intimately involved in their management. And by the way, 2 of our coaches are here in the audience, Bobby Glon and Brittany Volk. And this was a really intensive intervention in order to generate these results. The first thing we demonstrated, we've been told over and over again, yeah, you can put people on a ketogenic diet, but in the real world, nobody can stay on a ketogenic diet long term. So these are the data for blood ketones measured by fingerstick glucose and monitored through our app. And you can see that the group initially was above, at or above 0.5 out to 6 months. And then the second 6 months, as we added back, because we personalized the carb tolerance, or carb intake to the tolerance of the individual, but they're still maintaining an average of 0.4 millimolar beta-hydroxybutyrate, where 0.5 is, we used to think was the threshold of impact, and we think is actually better than, or lower than that now. So again, we had remarkable adherence to carbohydrate restriction for this group of people over that duration of time. Our focus was not weight loss. These people were told from the outset to eat this diet to satiety, and it was a high-fat, moderate protein, where we started out at about 30 grams of total carbs per day, and some of the people progressed upwards from there after the 3 to 6 months. And you can see the weight loss continued out to about 9 months and then plateaued for the last 3 months. Not the usual U-shaped curve of lose and gain back. And we had a whole bunch of things that we monitored, including their diabetes status, and Dr. Hallberg will report that tomorrow. But this shows the total white blood cell count for the usual care group up on top at baseline and at 1 year. And for the intervention group, started at in the normal range of value of 0.7 or 7.0, dropped to 6.5, and then down to about 6.2. And that doesn't look like a big change, but that would be equivalent to about a 10 to 20% reduction in coronary risk based on the published data from previous epidemiological studies. And the other thing is the consistency of this change. And you can tell the consistency from the p-value, and the p-value here is not 0.001 or 0.005, but it's 1 × 10⁻16. This is a very consistent change for people following a well-formulated ketogenic diet. So it really looks like this is hardwired into our biology. Take away the carbs, and you reduce the inflammation. We got more dramatic results with C-reactive protein. And again, remember, 2 is above 2 is considered where risk begins, and these people both groups started above 8. And then there was no significant change for the intervention group at 3 months, but at 1 year we cut their value down by about 35%, which is a really big change. So this is the same magnitude of change that one would get with the monoclonal antibody or with a statin drug. But we're doing this just by changing macronutrient intake and optimizing mineral nutriture. And I don't want to minimize that. We pay a lot of attention, not just to restricting carbs, but to providing adequate sodium, providing adequate potassium, and providing adequate magnesium. So this is a very potent, this is a drug-like effect. If we could put this in a pill and sell it, it's $1 billion drug. But the neat thing is you can do it just by eating real food. And it doesn't have to be expensive. Somebody asked in the previous panel, what do you do for people with low income? And my favorite source of fat is good quality olive oil. I buy it in bulk from my local big box store I will not name. But I was mentioning to some folks over lunch the cost of 1,000 calories of good olive oil. I don't drink it. I mix it. It's really unctuous and delicious in foods and sauces. 1,000 calories. Price has gone up recently, and it's up to 65 cents, 1,000 calories. Who can't afford that? And you buy a $3.95 latte. Anyway, I'll get off my high horse. So what are my conclusions here? What's there to say? There's no drug that's approved for chronic use that doesn't have side effects that can do this. And yes, there can be side effects to a well-formulated ketogenic diet, but they're manageable if you maintain adequate hydration, sodium, and minerals as some of the key associated factors you need to deal with. You know, someday down the road, we may get access to this gamma-tocopherol DHA combination. That could be put in 3 pills per day and costs about $1 a day. But until that comes along, it looks like our best hope is a well-formulated ketogenic diet. And this is something that pretty much, you know, many people, we could guess more than half our population would benefit from doing. It's not for everybody. And it's available to anybody who either wants to find the materials or seek out the coaching to be able to do it. And let me leave it at that, and thank you.